I want to first give recognition to Professor Hideyo Noguchi because, as many of you are probably aware, among the things that Professor Hideyo Noguchi was researching was yellow fever. And he actually died from yellow fever in Accra, Ghana. Today, Africa is facing the largest yellow fever epidemic in 30 years. And we are currently running in a shortage of vaccines for yellow fever, threatening a large population in Angola and in the Democratic Republic of Congo. So it's very timely that we have this workshop honoring Professor Hideyo Noguchi, and I'm sure that my panelists here, particularly Dr. Seth Berkley, will talk something about some of the challenges of providing vaccines during emergency conditions. So I wanted to bring this issue because it is very relevant to the legacy of Professor Hideyo Noguchi. I want to thank the people of Japan for both creating the Hideyo Noguchi Prize, but also for putting together TICAD even before the Sustainable Development Goals were announced, therefore driving us to the Sustainable Development Goals. I want to thank WHO and the government of Kenya in particular, and other stakeholders who have put this seminar today in place, and to thank the young scientists, the future generation who are here, because you will take the legacies of all of us, including myself, forward in the years to come. And I also wish to recognize the fellow laureates of the Hideyo Noguchi Prize who are here, Professor Miriam Were and Professor Brian Greenwood. So we have a distinguished panel here to discuss medical services. We also have a group of young scientists who have discussed this very topic, who will give us a perspective from their view of medical services and some of the challenges that we are facing in Africa. And on my panel, to my extreme left, is Dr. Jackson Kioko, Director of Medical Services of Kenya, who will give us a voice from the field. What is happening in Kenya? What are we doing in terms of achieving universal health coverage? To my right is Dr. Seth Berkley, who is the CEO of Gavi, the largest and perhaps the most successful organization for driving life-saving vaccines across the world. And in my view, vaccines are the equivalent of putting someone on the moon. They are as strategic and as important as that. So we'll be delighted to hear from Dr. Seth Berkley. To my left is Mr. Brian Richmond, Director of Crown Agents, who will talk particularly about how do we respond during emergencies, during epidemics, and in particular the place of logistics and supply chain. Finally, to my right is Dr. Koya Ariyoshi from Nagasaki University, who is a son of Africa, who had part of his training here in Africa and understands Africa very well, and will give us a perspective on how Japan can contribute to the global health goals and how Japan can help us in Africa to achieve universal health coverage. So I'll kick off with Dr. Jackson Kioko. We would like to hear in 3 or 4 minutes a report from the field. How's Kenya doing? What's the scorecard? Is universal health coverage in Kenya as good as Kenya is at Olympics for being the top African country in terms of medals at the most recent Rio Olympics? Dr. Jackson.
Thank you very much, Alex, and I can assure you that Kenya is at the top of everything. We lead, others follow. First of all, mine is to welcome you to this beautiful city of Nairobi. It's the only city that is next to a national park. So welcome to the Nairobi National Park. Ladies and gentlemen, I'll just give you the Kenya Health Delivery System in the context of universal health coverage. Very briefly, just as a background that Kenya has a healthcare delivery system, which is a composite of public and private facilities. 45% of these healthcare delivery system facilities, actually the private, which are mainly in the urban setup. Of course, there are 6 levels of care. the community health services level 1, and the national referral hospitals are the 6th level of care. The care package is usually defined by what we call the Kenya Health Package for health. Of course, this country has experienced a double burden of diseases, communicable and the rising burden, what we see currently, of non-communicable diseases, including cancer and other non-communicable diseases like cardiovascular and injuries. We're seeing a lot of that. Of course, just like any other African country, Kenya was not lucky to attain the Millennium Development Goals. However, we have made significant progress in terms of improving or reducing the burden of HIV, malaria, and tuberculosis. Of course, with notable improvement in reproductive, maternal, child and nutrition indicators. Of course, there are certain challenges that we note within our health systems. The challenges of access, equity, and coverages and sustainability of health services still remain. But in our country, we are making deliberate efforts towards, as we transition from MDG to SDG, towards building resilient and sustainable health systems that will ensure equal opportunities for essential health services to all Kenyans. Of course, we are more concerned in improving the health infrastructure, improving access, the quality of healthcare, training more health workers, and to ensure that there is more community participation in health services. Of course, we all know that universal health coverage is not a mean by itself, but a means towards achieving universal SDGs. Of course, as a country, achieving universal health coverage and ending the epidemics of HIV, AIDS, and malaria and tuberculosis, and the rising trends of NCDs like the cancer, and responding to public health emergencies like the Ebola and the yellow fever are some of the integral parts of a comprehensive approach in this country towards attaining the SDGs. Of course, as a country, we are putting strategic measures towards the implementation of universal health coverage to ensure that everyone, everywhere, is able to access quality health services without suffering from financial hardship. Of course, we have a constitution which is very much in place that assures that citizens have a right to quality and affordable health care. And our health policy, which spans from 2014 to 2013, which basically focuses on equity, access, patient-centeredness, efficiency, participation, multi-sectoral approach, and also the social accountability in delivery of healthcare services. Of course, this legal and policy framework, of course, demonstrates the Kenya's commitment towards implementation of universal health coverage. We have national programs and projects that have been put by this government of Kenya that will ensure the country is able to deliver health promises. There are health promises in the Constitution, health promises within the health policy. And some of these are the government has increased its domestic financing through increase in budgetary allocation. We have a program we call the Free Maternity Service that ensures pregnant women are able to access services from the time of antenatal to the postnatal care. And of course, we abolished the use of fee services in our primary health care services so that people who are in the rural areas are able to access services without any financial barriers. We have also a program of health subsidy insurance, which usually aims to protect, to cushion the elderly, the orphans, and the vulnerable population, especially people with severe disability. Another program is an output-based in the rural areas. They're usually given a voucher that they use to access care in facilities. The recent one is managed equipment services that the government has introduced that will ensure that we have decentralized medical specialized services in all the 47 counties. 2 of the hospitals in each of the 47 counties are going to have specialized equipment in radiology, in theater, surgical theater, in renal, and also in critical care. Of course, the last one is upgrading of the slum health services. As we want to ensure that people who are in the informal settlement in our urban areas also have access to quality care, just like their counterparts in other areas. Of course, the last one, moderator, is a costed investment framework for reproductive, maternal, neonatal, adolescent, and child health, a program that under the global financing facility that this country is going to further improve the reproductive, maternal, child health, and adolescent health services in this country. And we believe these are some of the approaches that this country has put in place to ensure we move towards universal health coverage and further to implementing the SDGs. Thank you very much.
Thank you very much, Jackson. My apologies. Can the rapporteur for the Medical Services Group please join us to the front? Thank you very much, Jackson. And I think we shall wait to see whether Kenya gets a gold, silver, or bronze medal when we do the first audit to see how we are progressing in universal health coverage. Let's shift gear. Health is a global public good. And therefore, being a global public good, we cannot stand totally on our own as a country, as Kenya or Uganda. There are many global health initiatives that are there to support this global health good. The Global Fund, PEPFAR, but a prominent one is Gavi, that supports particularly the poorest of countries to access cutting-edge technology in terms of vaccines. And it's my pleasure that Seth Berkley, who's the CEO, will introduce what Gavi has done, what it's doing, but also futuristically, how Gavi can help us to achieve universal health coverage and the Sustainable Development Goals. Seth.
Thank you, Alex. And I want to start by congratulating the Japanese government for bringing TICAD to Africa, and it's very exciting. And you've already made the point that it's very appropriate. We're here talking about the legacy of Dr. Noguchi, given the large yellow fever outbreak that's going on. And just to say a word about that, here's a fascinating case. We've actually increased the price of yellow fever vaccines by 500% over the last 10 years. There are 4 manufacturers that are pre-qualified, so you'd expect that there would be enough vaccines. But one of the questions is this vaccine is still being made as it was in the original Rockefeller Foundation days. And we find ourselves with this fabulous vaccine, which is a single lifetime dose, provides protection, but not adequate quantities. And the secret to that really is we now have to do a much better job of working on the demand forecast, understanding and giving enough time for companies to move forward, and also to incentivize companies to invest in better technology and improvements in manufacturing, et cetera. So these are some of the challenges that we have, and maybe in the questions and answers we can talk about them. But to go on to your question about universal health coverage, I think, for me, I was part of the Lancet a Global Health Commission for Global Health by 2035. And, of course, we were very keen to see that there was universal health coverage. And there's a couple of important points. Health is critical towards development. And, obviously, we need to have financial protection because people who get sick often get tipped into poverty. But one of the critical issues in thinking about universal health coverage is how does one implement that? And the Commission came up with the concept of progressive universalism. And the concept there is that countries should take the most cost-effective interventions, should try to get the widest scope for those as possible, and as they have more resources, add other interventions, and then more and more until they cover fully. Because the concern was that we don't end up with a veneer of very thin coverage or of funds being spent on things that are not cost effective. So, this to me is a very important philosophy, particularly in Africa. And of course, the most cost effective intervention is immunization. And immunization is special because if you look at this, it is the intervention that touches more lives than any other. So, if you look at Africa, 95+% of children on the continent have had at least one dose of vaccine. If you look globally, we have the highest immunization coverage in history. 86% of children receive DPT, a third dose of a DPT containing vaccine, which is the indicator we use for health services. Here on the African continent, that's around 76%. So those are great numbers, but what we're talking about is globally 14% of children not receiving it, and here on the African continent, 24% not receiving it. And so we've reoriented ourselves. Of course, our main goal is to bring new and modern vaccines for the great killers, diarrhea, pneumonia, now cancers, liver cancer, cervical cancer, and others to countries. We've done 135 launches in Africa over the last 5 years, and we'll continue to do that. But we've shifted to trying to improve coverage and equity. And this is really critical work because vaccines don't deliver themselves. If we have vaccines being delivered in the community, there is a health worker, there is a supply chain, there is a facility, there are the tools, and of course this is what the public health system is built upon. A couple of things are necessary to do this, though, and one is really critical, which is good quality data. Do we have the data at county level, at district level in other countries, to know what the coverage is, what the service delivery is, so that we can then target those areas? Do we have the political will for resources to preferentially go to places that have low coverage? Usually there's a reason places have low coverage. They're off the grid or they're politically not necessarily seen as the most important. We have to preferentially look at those. And if we do that, if we make that effort with the appropriate data, making an active effort and build those systems, we will then not only deliver vaccines, which is critical to saving lives, but also build the system that's necessary. And lastly, let me say that I'm looking forward for Kenya to have that gold medal here. Kenya was the first country in Africa that began an HPV demonstration project. They haven't yet rolled it out. One of the things we'll discuss while I'm here is whether they want to do that. This is the second cancer vaccine that would be rolled out in Kenya, but also how they're working to try to make sure there's equitable coverage across the country.
Thank you. Thank you very much. And perhaps what is often not recognized is we often assume that Gavi is a vertical vaccine delivery, but in fact, it invests a lot in health system strengthening and actually helps countries to respond to other challenges driven by funding along vaccines. Well, let's segue that things don't always go the way you would want them when you plan to improve the health of a country. Sometimes epidemics occur. Sometimes wars occur. Sometimes displacement of people occur due to drought or famine. Southern Sudan is going through one of the biggest challenges currently in terms of a combination of impending famine, breakdown of systems, and civil war. How do you get logistics? How do you get drugs? How do you get vaccines to situations like this? And I would like to invite Brian to talk about a particular case study as an example of some of the ways in which we can help those countries and those situations that are in great need, but that are in dire circumstances. Brian. I think there's going to be a few slides.
Good morning. I've got a hard job now because I've got to summarize 2 years of work in 5 minutes. And also I'm very nervous about following the Karate Kids as well. I'm going to talk to you about what we did in Sierra Leone over the last 2 years. Many of you know about the tragic outbreak of the Ebola disease. So let's just give you some background on what the situation was. Before we do that, I would just say that you're going to hear a little bit from me, but mostly from the people who were affected and the impact of the work that we did. So first film, please. Next slide, please. I think Dr. Rory mentioned the global village, and those were the headlines in the UK, and it became very evident very quickly that Ebola does not need a passport to travel. So, next slide. We were asked to develop a supply chain for, first of all, a 100-bed Ebola treatment centre funded by the UK government that quickly became 7 100-bed treatment centres. And what we found at the very beginning, which normally happens in these situations, you've got too many people chasing limited stocks of products. So, and there were 1,500 main items for each Ebola treatment centre, a massive task. But by being the single buyer in the market, we were able to provide best pricing. Some people even donated product for free, and we had an ability to develop a strategic partnership with the suppliers to understand that this was not going to be a short intervention, and we needed to talk about innovative production methods, and some companies even adapted and added new production processes. Next slide. We decided to put the warehouse close to the action.
So this is the type of return warehouse, which is the heart of the entire TICAD supply chain across the currently 6 Ebola treatment centers working here in Sierra Leone. So this is the platform which all resupply goes out to the different sites. So everything from various warehouses in Europe comes to Freetown, and then we distribute it out to the sites as requested. So this allows us both a buffer stock for things that we have in country, so we're able to rapidly deploy essential medicines and supplies as needed, but it also provides a platform for us to be able to take what comes in country and then distribute it out quite promptly.
We did encounter a number of challenges though. The Ebola treatment centres themselves wanted control of the supply chain. There was a lack of forecast data coming from these Ebola treatment centres, and much of the demand was guesswork. There was a huge unpredictability with regard to the disease burden, and there were many spikes. And as a consequence, the treatment centres started to panic and started to overorder items that were not needed. Next slide. So we adopted a hybrid approach, a mix of a push and a pull system. We put data capture managers at each of the Ebola treatment centres to get raw data, and we implemented an IT stock management system. We combined push and pull. We sent items based on their forecasts, but we also allowed them to place orders. The main key performance indicator was time, not financial. The mantra at the time was no regrets, let's save lives, let's not leave anybody behind. And agility was a big part of the response. For example, a northern push and mobile supply chains. The overall solution really was from pill to patient, and these are the results.
Extremely important that we manage to run an efficient supply chain.
Every time you go into the red zone, you have to be fully dressed in PPEs, including the woods, including the mask, including goggles, boots. So all this need to be supplied. So if you run out for a minute, then you shut down the program.
Thank you very much, Brian. Often in the curricula for public health, we are not taught enough in terms of logistics, supply chain, but clearly this is an important area. And I know that Japan pioneered the system of just-in-time delivery for manufacturing of motor vehicles. So sometimes the technology and knowledge that sits in manufacturing can be transferred into the technology of global health and into the technology of supply chain logistics to help us solve many of these problems. The other thing I can say with a lot of confidence is that if Dr. Hideyo Noguchi had been alive during the Ebola epidemic, he would have been one of the first to go to the front line to do both research and help with the Ebola epidemic. That was his character. So this is a good segue to Dr. Koya Ariyoshi. We would like to hear from you, your reflections as a Japanese doctor and scientist who has worked in Japan but also in Africa, and in particular to show how Japan can contribute to universal health coverage in Africa.
Thank you. I'd like to use the slide to share my idea. I'm very glad today to share my idea because as Professor Gautino mentions that I initially trained the junior doctors in Africa and then I did my PhD. Now I'm a professor in Nagasaki. Can I have next slide, please? And then next, please. And now really in Japan, as you see that we have so much high-tech medicines we enjoy. And then I have to admit that this is really useful. We have so sophisticated endoscopic technologies and catheterizations and all sorts of imaging diagnostic techniques. These are very useful. And the Japanese government now, they're promoting the companies to export these very expensive, quite fancy equipment to abroad, which is really useful. Next one, please. But at the same time, having had profound experiences exposed to the African medicines, I feel really strongly the gap between the Japanese medicines and then the rural Africa, and of course, and then the fancy technique is very good, but it's difficult to believe that is the final answer to fill the gap. Next one, please. Next one, please. However, Japanese technology are not just on the equipment, but also we have other areas that our Japan technology has contributed to the rural Africa. The one example is the ivermectin, the Professor Omura, who won the Nobel Prize by discovering this one. And now we have a new funding organization, GHIT, which is really helping more Japanese companies. They have a lot of seeds, making them involved in linking their drug seeds to the tropical diseases. Next one, please. And also we have a famous bed nest. As you know, Sumitomo Chemical is a pure chemical company. But they have got a special technique to integrate insecticide called perimethylene into the fiber, and using that fiber to make bed net. And now that bed net, or that net, is playing a major role in malaria control in Africa. And then the next one, please. Transportations, I think we should not forget, the Japanese vehicle, very strong vehicle, really helped bringing and then transporting the patient drug and also the vaccines as well. Next one, please. I think the TICAD is, I think, a good opportunity for all these health medical professionals to approach to Japanese government, Japanese company, letting them to involve in more global health. And another example I'm hoping to see is a low salt containing soy sauce. There's some Japanese company called Kikkoman has got a special technique to make low salt seasoning. Next one, please. We Japanese Nagasaki University, in collaboration with the London School of Hygiene, we are trying to, next one, please, to see there should be more Japanese technology that can be translated in the global health. Next one, please. And particularly as a clinicians, in Japan daily we are working on the patient treatment, and we very heavily rely on the biomarkers. And I have just recently found some Japanese company, they developed a new machines very cheap, but that can be used in a very peripheral level. I thought that it can be translated into the health centers in rural Africa. So anyone who are interested in applying this kind of technique, implementing this technique, see the impact of this kind of new Japanese technology, how can improve the health care in the rural Africa. We in Nagasaki University do Next one, please. More robust Ebola detecting systems, collaborating with Toshiba. My colleague, Professor Yasuda, demonstrated that works in rural Africa, in West Africa. Next one, please. And then some finger, vein, or facial recognition system that should innovatively improve the personal recognition system, which is very important to improve health systems in Africa. Next one, please. And also new drugs and new vaccines for neglected diseases. Next one, please. And also, I think our colleague now with the big grant from Bill Gates, we're trying to demonstrate the reduced dose of pneumococcal conjugate vaccine. So next one, last one, please. So this is my final message. I think there should be more Japanese companies, and their technology can be utilized for improved universal health coverage in Africa. So please join us, Nagasaki University, us, and think together with us to get them involved in. Thank you.
Thank you very much, Professor. And not to forget that Japan, through JICA, has contributed a lot of money in Africa for infrastructure development, for procurement of vehicles, and all of these are helping to contribute to universal health coverage. So our last speaker is our rapporteur from the young scientists, and we will ask you to introduce yourself and give us a very brief summary of the thoughts of the group.
My name is Joseph Okebe. I work at the Medical Research Council unit in the Gambia. On behalf, I was speaking on behalf of the young scientists. We had some discussions this morning about looking at universal health coverage, health medical services from our perspective. Now, I think we have a slide here. Yeah, so next slide, please. So I think most of us will agree that I think most of us would know that the problems are always enormous, and in terms of trying to, we cannot solve all the problems. So from our perspective, we pointed out a few key things. One of it is regards to human resources for health. Now, the critical questions which we feel should be addressed are the questions about the what. What resources do we need? Where do we need them? How should these resources be distributed? And what are the incentive packages that follow these resources that that needs to be put in place for us to achieve universal health coverage? Now, the other thing we also looked at is health systems. Now, I believe every country has its own health systems, but then we need to begin to look at how we can learn from each other. Systems within countries that are working, how do we extrapolate these systems to other countries or within regions within Africa? Now, we know that there are obviously many barriers to health, but I think one of the ones that everybody comes to mind is issues about access. But we also want to bring to this meeting that there are other things that also constitute barriers to health, not just access. We're talking about acceptability of health systems. How do people perceive these interventions that are being put in place? Do people actually want these interventions, or do they prefer them in different packaging? Now, we also talked about looking beyond government sector systems. Now, we've drawn, there are quite a number of examples, especially from Japan, where the issues around funding for health systems are not just being driven by the government. So we actually consider that it's important that we have a system that is specifically addressed to different sectors. Now, we know the most popular is the government systems, but we know that in some places the private health systems can also support health insurance. Now, also within local communities, there are also community-based insurance systems that are in place. These can be explored and improved upon. And of course, more importantly, we need to have our leadership, governance, and accountability systems in place. It's good to talk the talk, but I think we also need to put more action and evaluation on whether these things are actually achieving the purposes which we want them to achieve. And next slide, please. So interestingly, a lot of us are, have backgrounds in research, so we also wanted to find out how, what are areas of research can link, into providing effective medical systems. Now, one of the things I think a lot has been talked about here, it's about translation and implementation research. We really need a lot more of this to see whether what we're actually putting in place is actually delivering as expected. Now, we also talked about synchronized funding. There's a lot of goodwill, both from the Japanese government, improving resources that can, improve our systems. We also felt that perhaps, we could also look at how this could be integrated. So the number of funding organizations that are interested in improving the quality of life in Africa, maybe they should, sit together and have, a comprehensive approach to this. And, just like last speaker said, I think there's a lot that we can do with IT. I know that in most countries, even people that can't read or write have got a mobile phone. So I think these are some of the things we should, explore to see how do we improve on these platforms. So thank you very much on behalf of my colleagues who've actually enjoyed the meeting so far, and thank you again for inviting us. Thank you.
Thank you very much, and thank you to all the speakers. I mean, clearly, having visited Japan several times, one of the things that strikes you about Japan is how old people get to live productive lives. My mother is 91 and alive, but she's not as productive as some of the 91-year-olds that I've seen in Japan. And I think we need to recognize that in Africa, our life expectancy is growing, which is great. We are living longer. But we need to understand what is the quality of the lives that we are living. So my push is also there are many learning moments that we can, by looking at Japanese society, to see how do people continue to live 30 years after stopping work, what's the quality of life for geriatrics, what is geriatric medicine like, and so on and so forth. So that's my little contribution to this debate. I will now put it open to questions. We are running a little bit in terms of time, so we will try to restrict in total, since we have 5 panelists, we will do a first round of 5 questions and then see how long it takes to answer those questions. So please put your hand up. Who is helping me to take a microphone to the speakers? Yeah, absolutely. So use the speaker system in front of you. And please, one question, just one brief question, and indicate who that question is to among the speakers. So who would like to get the ball rolling? Is your system working there? Okay, I'll let you use this.
Thank you very much. My name is Alex Igbefia, Minister of Health of Ghana. Mine goes to the gentleman, a colleague who dealt with the supply chain issues. It was a mammoth task to actually put this supply chain process together. That information rests with you. How are you disseminating it into Africa for us to begin to actually use it, or at least have it in place, so that if we get into a situation like this, we are in a position to actually deal with it? Thank you.
I think we'll answer the questions as they are asked, yes. Thank you.
Okay, thanks for your question, Honourable Minister. First of all, I'd be delighted to come to Accra and talk to you about it. I started my career with Crown Agency in Ghana, so I'd love to come back. We are using that experience and learning at the moment with the government of Sierra Leone to rebuild the fractured health systems there. So it is being used in that context, but certainly it has a place to be shared across Africa, and be very happy to share that with you at some time.
I could add, Minister, that I and my organization, currently Partners in Health, is setting up a brand new university in Rwanda called the University of Global Health Equity that looks at what is required for global delivery of goods and services. And among those are logistics, supplies, supply chain. And I will be connecting with my colleague here to be faculty on this university so that we can bring this and keep this information in Africa. A really great question about building capacity in Africa to do these things. Next question. Yes, at the back to the right.
Thank you very much. My name is Bright Edu from Noguchi Memorial Institute for Medical Research, Ghana. My question goes to the same speaker, and it has to do, so what happens now after Ebola? Have you packed out of Sierra Leone, or you are still keeping some stock there just in case? There is now epidemics. I just heard of yellow fever. The time frame, the time it took for resources to be mobilized to help with Ebola, I believe contributed to the extensive mortality we saw. So what is happening now to, be able to quickly mobilize resources should such a thing happen again? Thank you.
Okay, thank you. In short, we are still holding strategic stocks, both in Freetown and in the UK. We're also using those logistics infrastructure that have been set up for other programs. So the 3 healthcare program that the government of Sierra Leone has launched for essential drugs is going through that logistics infrastructure. But we're also working closely with people like UNICEF to look at preparedness, because you're right, people did move very slowly, and 2 or 3 months were lost.
Dr. Seth wants to comment on that.
I just want to add a comment, which is we underappreciate the power of professional logisticians. And so one of the issues, if you look in the health sector, often, for example, in immunizations, which every country has in immunization systems and logistics, they're often run by a medical professional, a nurse, sometimes a doctor, and of course these are least well-trained people. So one of the things that we've tried to do is create training now. There's a new training center in Rwanda that I hope links up to your university. There'll be one for Francophone countries as well, and we're looking at one in Asia. And the idea now is to go ahead and train professional logisticians who can be part of the Ministry of Health and use modern techniques to do that. One request, though, for all of you is that to do that, we need to have positions available for professional logisticians and to appreciate that work as a part of what is being done in those countries.
Thank you. My personal comment to you, Minister, is that many of our African countries, we have large armies. And of course, the primary responsibility of an army is to defend the country from threats outside the border. But if there are no threats currently, how do we mobilize the army and other government agencies to develop speciality in this field, to be the first responders to emergencies, to learn all of these skills that are required? I think some countries are utilizing that spare, I call it spare human capacity, to be able to respond to many threats, whether it be famine or drought or floods. But this could be another innovative way that we use capacity in country to respond to these kind of challenges. Other questions? Can we? Yeah, all right. We can't see your face, but I'll hear your voice. If you could stand up, yes, yes. And come, yes.
Bonjour, je vais me lever pour qu'on me voie. Je suis Noguchi, j'avais dit, je viens du ministère de la Santé du Congo, conseiller technique.
Une minute.
Channel 1 is for English.
Donc, je disais, je suis Muyukani, je suis conseiller technique du ministre de la Santé au Congo. Deux petites questions, en 1 minute les deux. Il y a plusieurs pays qui sont en épidémie de fièvre jaune actuellement. Et on sait que le vaccin, les quantités sont limitées, il coûte cher. Que peut faire Gavi pour faciliter l'accès au vaccin? 1, 2. Nous sommes très intéressés par l'expérience, ça s'adresse au Dr Jackson. Nous sommes très intéressés par l'expérience du Kenya en matière de couverture universelle. Au niveau actuel, est-ce que vous pouvez nous donner 2, 3 leçons à tirer de votre expérience? Thank you so much.
So yellow fever vaccine, as I explained, is a relatively inexpensive and old technology. The challenge is not so much the emergency stockpile. We provide 6 million doses a year, and this year that was exceeded. So far, we've purchased 18 million doses for the stockpile. The challenge has been that the coverage level for routine yellow fever has been relatively low, and that was true in Angola. And so one of the questions now is whether countries will increase the use of routine yellow fever. And WHO is redoing their risk assessment to ask the question, you know, where should countries be using it as a routine vaccine? And then in countries that have high risk, it takes a long time to get population coverage. So what we do is large campaigns. And again, the question is being asked, should we now do campaigns? Because it looks like yellow fever is shifting from a sylvanic cycle, which is you know, people living near the forest, being exposed, and then the strategy has been to surround those people with vaccinated people to stop the epidemic. But now when it moves into big cities, it creates a much bigger problem. WHO has recommended at this moment in Kinshasa diluting doses to 1/5 of the dose to expand the use of vaccine. This hasn't been done before. It should give strong immunity, but we'll need to follow it for how long that immunity will be provided. Lastly, if the emergency was to spread, we of course could take vaccine that exists for use in routine and make it available for emergency situations, but that would mean that some of the routine vaccines would be you know, stopped. So a lot is going on this, and I think the most important is these long-term plans to work with industry to make sure there's more vaccine available.
And I would ask our colleague from DRC, after the meeting, there are many senior Japanese officials here. I am sure this is an area, given the legacy of Dr. Hideyo Noguchi, they may wish to discuss how they can help. You know, I often ask a quiz question. Which are the 3 cities in Africa that have more than 10 million people? And people can tell you Lagos. Some of them can remember Cairo, but very few people know that the third is Kinshasa, that Kinshasa has more than 10 million people. And an epidemic of yellow fever in Kinshasa would be a total disaster. So the last question was to Dr. Jackson about 2 lessons, quick lessons that can be transferred to DRC for universal health coverage.
Thank you very much for that question. I think one of the key lessons that we have learned in this country is that for us to be able to move towards universal health coverage, there are key things that need to be done. One is to deal with the epidemics, the burden of communicable diseases. As a country, we've realized that the burden of malaria, TB, and other infectious conditions still remains very high. And most of the Kenyans are actually, 30% of our Kenyans are using out-of-pocket to finance healthcare, mostly towards malaria, HIV, and tuberculosis. So reducing the burden of these infectious conditions is one of the key things that will drive your country into that regard. And the second thing is the financing aspect. We need to come up with strategies that will cushion the population. Nearly 50% of Kenyans live before the poverty line. Of course, that means that they will not be able to afford the cost of health care. That means then we needed to come up with financing approaches that will ensure we cushion this kind of population, including those who are vulnerable. At the moment, our National Health Insurance Fund is undergoing major reforms. And what we want to ensure is that these more of our Kenyans actually are enrolled into National Health Insurance Fund to be able to access health care. We've already expanded the benefit packages even to cover the non-communicable diseases, including cancer, the renal diseases, and the cardiovascular diseases. And these are some of the key things that I would want maybe DRC Congo to learn and maybe to drive your country forward. Thank you.
Thank you. And I think it's only appropriate that we end this discussion by asking Dr. Seth, where are we with an Ebola vaccine? And if we find it, what will Gavi be doing to help Africa be protected from Ebola in the future?
So we're lucky because we do have an Ebola vaccine. In trials in Guinea, it showed 100% protection in relatively small trials, so the confidence intervals are wide. We've created an advanced purchase commitment to have 300,000 doses of that vaccine ready to go. It's ready right now, so if there's another outbreak, it can be used whilst the company is working towards getting it licensed and pre-qualified. I think the challenge in front of us is not just that vaccine, which is Ebola Zaire, but vaccines that will cover all of the Ebola strains and Marburg as well. So how do we put incentives in place for companies to invest in further research and then also to create preventive vaccines? And the reason that's important is the way we diagnose Ebola in Africa is some child or a person comes in with what looks like malaria, then all the health workers in that clinic die, and then we know there's something happening and others die. That's the mechanism that we do it, and if we could vaccinate all of the health workers and frontline workers, we wouldn't have to have those deaths be part of the way to diagnose an epidemic. So work is being done on creating a target product profile for a long-term preventive vaccine. It might be the existing vaccine, it might be another one, but there are others that are available as well.
Thank you. And finally, just to remind us that Japanese investment in development of Africa goes far beyond the health sector. But there are many investments from Japan that can be applied to the health sector. I work in a very rural area of Rwanda. Many of the needs in these rural areas is they don't have lighting for the clinics. So solar power is an area that I'm sure Japan knows a lot about. Many of these clinics need refrigeration for drugs and for vaccines, and I believe Japan knows a lot about refrigeration. All of these clinics need IT and a way to communicate, and I believe Japan knows a lot about this. And of course, everywhere you go in Rwanda, it is a Japanese car, usually a Toyota, that is transporting patients. So I appeal that we engage this broader Japanese sector and Japanese interest in the development of Africa to help us improve our health systems. Thank you very much for listening to this panel, and thank you to all of the panelists who participated.